I always like to begin with the end in mind. And when we talk about the economic sciences, there are a couple of edicts that I wouldn't say that are always adhered to or even partially adhered to, but are very critical in terms of our assessment of results. And those two edicts, the first of which is that when we study decision making involving scarce resources, we first have to understand who gains and who loses. And the second edict is that we have to understand what happens in the short run as well as the long run. And those may seem to be fairly simple recommendations to follow, but the implications of that are actually quite large. If one follows those edicts, we have comprehensive analyses, truly comprehensive analyses. And really, the way that that applies to today's presentation and the research that I'm about to discuss, it means that we not only follow and analyze the intended consequences of decision making, but also the flip side of that, and that is the unintended consequences. And as a prelude to this talk, I almost want to jump right to the findings, because they are in some ways horrific, amazing, but there is a happy story somewhat at the end. This investigation actually looked at legislative changes that were implemented in the state of Arizona involving reimbursement to podiatrists. And essentially what happened is that in the fall of 2009, under the state Medicaid program, reimbursement was cut. The announcement for reimbursement was cut. It was implemented over the next several months, and we set out to analyze the unintended consequences of that legislative act. And this research was initially presented at the American Diabetes Association, and since it has been updated, and the results, first of which are being presented here, it's really garnished a great deal of press. Some of it not so favorable, some of it quite favorable in terms of the advocacy realm. But just a few weeks ago, maybe a little over a month, we were interviewed by a U.S. Senator's office and a U.S. House of Representatives office and the Congressional Budget Office concerning this study and a few others. But it is to support changes, and the bills are introduced and they are currently in committee, but it is to change the reimbursement policies for all Medicaid programs across the United States to allow for the care and treatment of, expanded treatment of the diabetic foot. So very happy, I think, sort of medium out of this. Our only conflict that I'd actually state for this talk is would be against uninformed decision making. Some background and purpose. I mean, as was sort of introduced, part of the other work that I do involves cancer. And my interest in the diabetic foot really follows that these are cost drivers and also quality of life indicators, and they really have a huge impact in morbidity and mortality. Again, as was sort of introduced today, when we are talking about amputations involving the diabetic foot, the 5-year survival rate really does push that of lung and pancreatic cancer. And I see this every time I run analyses. I don't know that the public is so informed. Some other research that we presented at the American Diabetes Association involves inpatient admissions. This is over 10 years from 2001 to 2010. 66.1 million hospital admissions involved a diagnosis of diabetes, 17% of admissions. And about 4% actually involved the diabetic foot ulcers. And as you can see from this graph, it's pretty much flat. So in some ways we're making strides, and we hear about these strides, but overall we're really not having the kind of impact that we should at the population level to prevent these conditions from getting to that latter stage of inpatient admission. In terms of money, $2.4 trillion across the 10 years for diabetes. And when I see these numbers, they become blurred. This is Medicare. All of Medicare equals that bill. That's the toll economically that diabetes has. In terms of diabetic foot ulcers, $113 billion. Well, that's not nearly as much of a bill for that. But if you were to sum up all hospital-borne infections, that's what that figure would approximate. A tremendous impact. Now, as I summarized earlier, the study purpose here was to assess changes specifically in inpatient hospitalizations that were associated with diabetic foot ulcers among adult beneficiaries to Arizona's Medicaid program called Access. And I don't know if the title was really appropriate, so I subtitled, perhaps this study should have been called Access to Access. So this followed the 2009 announcement of coverage cancellation to podiatrists intended to reduce $351,000 from the general fund. 351, remember that number. The study methodology, I thought I would show graphically, is that what we did is we looked at a historical control. We looked at what happened from 2006 to 2009 and then applied that variance to the announcement and the signing and the implementation of this legislative bill, and essentially assessed those differences. There's a little more involved than that, but it's a rare example and a rare instance, the first time in my career, that I was able to conduct in economics what we call a natural experiment. And we adapted from the economic sciences a study that I had published on, actually for my master's and PhD, the event study methodology, which ironically won the Nobel Prize in economics this last year. So it's retrospective data, cross-sectional. Again, we collected from the feds, AHRQ, State of Arizona Hospital inpatient discharge records. So that's representative for all of the inpatient discharges in the state. So our policy analysis involved initially the policy announcement, which occurred in 2009, the legislative signing that we analyzed as a sensitivity analysis in March of 10, and then the reimbursement implementation. Inclusion criteria, there's no definitive definition that exists out there on what a diabetic foot ulcer should actually involve in terms of diagnostic codes. So we used a validated measure. Again, these are Medicaid recipients 18 years of age or older. We took a multivariate approach. Our outcomes, there are 4 outcomes that we actually analyzed. One were the number of cases that went into the inpatient setting. Second, inflation-adjusted charges. Third, the length of stay. And then finally, severe aggregate outcomes. This involved inpatient death, surgical complications, sepsis, or amputation. The control variables, post-announcement time period change, the patient demographics, and a case mix comorbidity scale that basically it sums up to a certain number to say, okay, higher numbers mean we have a sicker patient. Something else that we actually analyzed as well were the changes in Medicaid beneficiaries that occurred over time, because with the Great Recession in 2008, one would have expected a little bit of a bump in terms of the overall number of Medicaid recipients. Actually made our numbers look worse. because that bump actually went back down when this announcement period came into being. The statistical procedures, for those that are interested, is something called an ARIMA. This is an autoregressive integrated moving average, an interrupted time series. It's sort of the statistical depiction of that graph I showed initially. We applied what happened before the announcement period and then analyzed what happened after. Fairly straightforward, and the diagnostics and the other statistical nuances are here for your interest. Results. This is what I wanted to jump to almost immediately. These are the results. And it is a signal that is so strong that my 2.5-year-old son could probably understand this, and you really don't need to wrap any advanced statistics around. Point A is the time of the announcement. B and C involve the legislative signing and the implementation, and we see a skyrocketing of inpatient admissions and a plateauing effect that occurred as well. Now, the dotted line are diabetic foot ulcer cases overall in the U.S., and if I were to show in terms of Arizona beneficiaries, the percent change of Arizona beneficiaries that were enrolled in Medicaid, it's about as flat as that graph entails as well. So can't be really explained by an increased number of individuals going into Medicaid. I'll explain more of those sort of results as we move forward. The average case, just over 50 years of age, male, white, residing in large metropolitan areas, most cases, almost 3/4 coming in through the emergency department. And this comorbidity index that was actually developed in the 1980s and has been validated since, it was a small change, but it was a significant one. And that's actually quite a big jump because that number is bound at the highest level by about 16. So this is indicating that the case mix that was going into the emergency department and the hospital were actually a little sicker. Unadjusted outcomes. 35% increase in inpatient admissions, 40% increase in charges. So referring back, $350,000 saved, okay? Length of stay, 122 days per month extra, 24%. And at the very bottom, you really can't see, it pushes about 45% increase in severe aggregate outcomes. When you adjust for Medicaid, the Medicaid beneficiaries, there it is, 47%. When you adjust in that model and look at the change in beneficiaries, it goes up to 49%. So about a 50% increase in, not minor things. Death, sepsis, amputations, and surgical complications. Just for transparency, the descriptive statistics, we actually went through these. No major changes pre and post announcement. In terms of the inpatient case characteristics that we already really reviewed, number of admissions, pretty much every outcome that we analyzed was impacted. The multivariate approach really showed the same thing. I mean, again, you can wrap statistics as advanced as you want around this. The results are very, very consistent. About a little over 30% increase in hospitalizations, charges, lengths of stay, 20%, severe aggregate outcomes, again, 45 to 50%, depending on what you include as control variables. So when we first saw these results, it was just, honestly shocking. The sensitivity analysis, we actually, as a discipline, know very little about the way information is consumed in the healthcare markets. In the financial markets, we actually know a lot more. Information is usually consumed immediately. And to a certain percent, it can be incorporated perfectly or with varying levels. And it shows that markets are forward-thinking. And the research concerning the healthcare markets actually here supports that healthcare markets are exactly the same. They're forward-thinking, information is incorporated almost immediately, and patients and physicians begin to hedge risk. So when these announcements hit, patients said, you know what, I'm hearing about these announcements, I'm concerned I'm going to get a bill. Physicians, on the other hand, will say, you know what, am I going to have liability by treating these patients that come in? That's what this is sort of supporting. The sensitivity analysis, the results are entirely consistent. In terms of discussion, and what's highlighted here, so a cost benefit, this is not the way you conduct a cost benefit, it's not the way that you should follow decision making. But for every dollar saved, that is $350,000, $351 saved from the annual fund, resulted in $16.7 million incurred annually. That's a $1 saved for $48 spent only in hospitals. Believe it or not, that's actually pretty consistent with what the research has shown in terms of the cost effectiveness of preventative care. The prevalence of foot and wallet, we argue that it's understudied. I had another name for this that comes from management with the acronym KITA, kick in the blank. But we have seen that many Medicaid cost containment programs have failed to reach their goals. That what happens is that individuals will shift to more acute settings, and often what happens is that there's an inappropriate reliance upon emergency departments and hospitals as substitutes. So it's pretty consistent. 3 studies. Steve Sumerai, New England Journal of Medicine, found that the addition of a $1 copayment, just $1 going in for Medicaid recipients for prescription drugs, resulted in a 35% decrease in the use of study meds and a 2.2 times increase in the risk of being institutionalized. So it was a very effective barrier to going in and getting meds and ultimately being in an inpatient setting. And the statewide savings just disappeared. They were essentially canceled out by even looking at nursing home admissions. In the Journal of Health Politics, Policy, and Law, they actually analyzed 36 states and the District of Columbia to look at various programs trying to target enrollees' access and use of healthcare services. And what it found is that it didn't really influence utilization, but rather access to care. So they were getting care, but it was usually in a hospital setting, very expensive. And more recently, in the journal Science, some of you may have heard this, it made the national news. They evaluated the state of Oregon's lottery-based expansion program for Medicaid and found that individuals, when Medicaid was expanded, what happened is that they inappropriately went and used the emergency departments, even when most of those conditions could have been treated in an ambulatory setting. So in some ways, the results here were sort of flipped, in that there was a lot more inappropriate use, and that potentially there should be some incentives that exist to allow people to seek ambulatory care when appropriate. Now, the limitations here, the main one is that we were not able to analyze outpatient care. And part of that reason is that Medicaid sits on those data. And Medicaid does not want to share those data, and we can't get it. It's the major limitation of this study. We cannot get access to true Medicaid data. The conclusion, I think, is fairly forthright. The cancellation of podiatrist reimbursement within Arizona's Medicaid program was associated with marked increases in hospitalizations, and that drove costs, it drove length of stay, and we saw that severe aggregate outcomes were just spiraling out of control, and that restricting access to care may result in unintended consequences, and unfortunately not studied nearly enough with policy decision making. Thank you.